Thank you very much for this nice introduction. Assalamu alaikum, bismillah ar-Rahman ar-Rahim. Before starting, I would like to thank the organizer for giving me this opportunity to talk to you today. So as you know, the number of patients affected by diabetes and chronic kidney disease is increasing, and it is huge. If you look to this slide, and this is a little bit old, it's from 2022, and now maybe it's much better, more. The number of total patients worldwide affected by diabetes is approaching now 600 million. And most of this patient is type 2 diabetes. Unfortunately, around 40% will be affected by chronic kidney disease. And if you see that only 10% of those who are affected by the chronic kidney disease will reach end-stage kidney disease. And this is mainly because they will die in between due to cardiac complications. And if you can see that this is interrelated between diabetes, heart, kidney, and now it's becoming more and more important to think about this issue globally and not to take a small piece of patient apart. Moving to diabetes with chronic kidney disease. Is it a special case? In fact, each one will affect the ability of the other to adapt with fasting, and they have synergetic effect on increasing the complications. I will just give some quick two examples. The normal kidney concentrate urine up to 1,200 milliosmol per kilogram of water, and could dilute the urine up to 50 milliosmol per kilogram. So the urine osmolarity could vary between 50 up to more than 1,000. This depending on hydration status. When the patient starts developing chronic kidney disease, the both abilities of the kidney will be first affected by the process of chronic kidney disease and get worse and worse by deterioration of kidney disease. So as you know, plasma osmolarity is between 275 to 295 milliosmol per kilogram. When the patient reaches almost end stage, the urine osmolarity will vary very little around the plasma osmolarity. So the patient, if we deprive the patient from fluid, it will be very hard to the kidney to maintain or retain fluid. And if we give the patient a sudden load of fluid, it will be similarly very hard to the kidney to excrete free water and prevent hyponatremia, for example. So this what happened or could happen in a patient with severe renal failure and fasting, especially when we have, for example, in top of fasting, the patient develops hyperglycemia, which induces the osmotic diuresis and put the patient at increased risk of acute kidney injury. And the opposite will happen when the patient breaks fasting, and if the patient drinks too much water in short time, this will put him at the risk of hyponatremia. On the other hand, you know that the kidney is the main organ metabolize the insulin, and with the development of chronic kidney disease, which could deteriorate further, the half-life of insulin will increase, whether it's endogenous or exogenous. This might expose, especially when we talk about exogenous insulin might expose this patient to increased risk of hypoglycemia. So, I talk about practical aspect that we are facing every day when we have consultation with this patient before Ramadan. And I will focus mainly about renal aspect because there are many excellent lectures about the aspects related to diabetic and fasting. So our approach is what we call it 3 A's plan: assess, advise, and assist. So we start by assessing the risk of complications. Then we give advice to the patient whether to fast or not. And if the patient decides to fast, our duty is to assess him to do it as safe as possible. We'll have some case scenario. Mr. Saif is a 65-year-old male, retired with type 2 diabetes for almost 15 years. He's planning to fast with the expected duration to be 17 hours. He has some hypoglycemia attacks at the average of once per week. His blood pressure is acceptable. He has urine albumin to creatinine ratio at the level of 26 milligram per millimole. His eGFR is 26 milliliter per minute per 173 meters square. This is putting him at the level of stage 4 CKD. His A1C is 7.5%. He's on premixed insulin, 2 doses, with treatment for hypertension, telmisartan, amlodipine. So what is the risk to develop complication? If we use the risk calculator, we can see that he's type 2, so 0, he has more than 10 years of diabetes, multiple doses of insulin, and expected fasting time more than 16. So this will give him 3.5 point in the risk scores. He has 1 episode in average of hypoglycemia per week, so this is another 1 point. And there is hemoglobin A1C is 7.5, so this will give him 0.5. But when we move to the risk score with the chronic kidney disease, we find that having eGFR less than 30, this gives him 6.5 point. So already he is moving to very high or high risk group. And based on that, our advice to him that to not fast. And we try to convince the patient to not fast, but it's not always easy, or patient will, some of them will fast. So here our duty is to assess them to do this as safe as possible. And we have, in principle, 3 clinical visits at least to help them pre-Ramadan, during Ramadan, and post-Ramadan. So pre-Ramadan, we try to assess again the condition of the patient and give the patient, educate the patient what to do, etc. I will not go through that for sake of time, and there's nothing special in this. During Ramadan, usually after 1 week, we try to assess the kidney function with minimal blood test, and we see the patient if he's okay or any complication happen. If all going fine, patient will continue fasting, and we see the patient after Ramadan 1 week or 2 weeks, then 3 months, to assess this experience and to readjust the treatment if it was changed, etc. What is important for this patient is education. As I mentioned, for the water, for example, and for the food, we advise them to break the fast slowly. So what we mean by that, do not drink too much water at once, do not eat big meal at iftar. So our advice practical to have a cup of water and maybe one date to break fast and go to the prayer. Of course, if there is no risk of hyperkalemia, the diet will give sugar, it's easily digested, so the patient will have some absorbed sugar to the circulation, and this might help him to reduce the appetite to eat too much. Then after that, patient, after prayer, take another cup of water and have light meal, go to Taraweeh, and during Taraweeh he might have a little bit of water, and after Taraweeh he might have his meal. We advise this patient to have around 2 liters of water or fluid over the night. Of course, not in severe renal failure with stage 5 or more, but with stage 3 and 4, it is reasonable to have 2 liters of water over the night, but spread as I mentioned. And and we advise them to have well-balanced diet. And if you can see, I stress on 3 points: break fasting slowly and gradually, drink at least 2 liters of water, and stress on eating sahur, as it is the sunnah, and also it will minimize the practical fasting time. Now, second case, Mariam is a 55-year-old with type 2 diabetes for more than around 14 years. She has good glycemic control with rarely hypoglycemic attacks. She works indoors, and fasting time expected to be 14 hours. Blood pressure okay, GFR 65 milliliter, and albumin to creatinine ratio 0.6 with A1C 7.7. She is on this medication, 3 for diabetes and 2 for blood pressure. So what is her risk? The first question, does this patient has diabetic kidney disease or diabetic nephropathy? Now, if you can see that we moved from terminology of diabetic nephropathy to diabetic kidney disease. Most authors now use diabetic kidney disease. What is the difference? Diabetic nephropathy is clinically characterized by persistent albuminuria in a diabetic patient in the absence of CKD or other causes of CKD. So we have diabetes plus proteinuria, and we don't have other cause of CKD. Now, diabetic kidney disease, we have 2 types, proteinuric DKD and non-proteinuric DKD. Proteinuric is the same as diabetic nephropathy. Non-proteinuric, it is a patient who has GFR less than 60 milliliter per minute, diabetic, and no other cause of chronic kidney disease. So, it's over the time? Yeah. Anyhow, this is the definition. So this patient, in fact, has low risk, and what I want to move to the third case. So this patient can fast. The third case is kidney transplant, a 50-year-old with 8 years type 2 diabetes and 10 years post-transplant. The patient, eGFR is 42, blood pressure okay, no rejection in the last 2 years. And it is on this medication, including immunosuppressive medication, tacrolimus, MMF, and prednisolone. Now, is he low risk or high risk? If we take the calculator, we can see that his risk score is 4.75, so it's moderate risk. Now, what is important for kidney transplant, on top of what we talk about the diabetes and CKD, that patient, usually we don't allow them to fast in the first year post-transplantation because we don't have enough data to confirm safety of transplant fasting. In fact, especially in the first 6 months post-transplantation. But usually we ask them to not fast, even if they have, based on calculation of other risk factor, they have 0 score, we ask them to avoid fasting the first year. And the other thing which is special for this patient is the immunosuppressive medication. We have, usually most patients are on triple immunosuppressive medication. We have the MMF, tacrolimus or cyclosporine, and prednisolone. So usually this medicine, especially calcineurin inhibitor, is given twice daily. So and it has narrow therapeutic window. It is a problem when we have fasting time more than 14 hours. So we have to take all this in consideration, and I will stop there. Thank you.